Dr. Tirone David. You are a legend in cardiac surgery. We met a couple of years ago. I just want to have a brief question for you. That's what make you decide to develop this David technique?
Well, medicine and surgery is no different than in other part of our culture. It's a stepwise. Take what we have knowledge today and try to improve. So back when I started practicing in the early 80s, there was no practical aortic valve repair. And one of the most common cause of aortic insufficiency in North America is root problem, not cusp problem.
Yeah.
The cusp become a secondary problem in the root dilatation. So we started to develop various techniques to correct the root dilatation and preserve the aortic valve, which after 5 or 6 years of different procedures, we came up with the reimplantation, which now, 35 years later, we know that it's the only durable valve repair for patients with aortic aneurysm.
And compared with another technique we all know is bento.
Bento, we're going to hear a paper today. Valve repair requires a special set of skills.
Yes.
It's not easily reproducible like a bento is. So perhaps for the surgeon doesn't do very many valves a year, a bento is a safe operation than a valve repair. But undoubtedly, if the patient is young, it's going to have an adverse effect on the patient's survival.
Yeah, for young surgeons, that bento is easier and safer, and for David, you need a lot of experience.
Much more experience.
And it's already 30 to 40 years. How about the long-term result and the life quality?
We're going to be published soon. 30 years outcome. 90% of patients still have a normally functioning valve.
Okay. How about the re-intervention?
Reintervention about 5 or 6%, but
in how many years?
Over 30 years.
Over 30 years. Only in 5 to 10% need the re-intervention. That's a very great result.
That's why I'm a bit, when I hear today the presentation, their reintervention is way too high. But if you take a look at the sample size of this experience publishing later today, or presenting later today, 316 patients were operated by 46 surgeons. If you divide 316 by 46, over 5 years, that's not a very good experience. I do 40 or 50 per year, so we are able to a bit better operation to do alone.
And normally we perform David and the aneurysm of the aorta root, but how about the acute aortic dissection? That is safe to perform?
I think is the best operation for the aortic dissection quite honestly, because there's no bleeding in the end, and you can save most aortic valve. But it compounds the operation, makes it for a long operation, it takes an hour and a half to 2 hours to do reimplantation. In the aortic dissection, likely the most important thing is to save the patient's life. So I don't think we should force valve sparing and compromise the outcome. Do an operation to keep the patient alive, and then let somebody else do valve sparing later.
Okay. Thank you very much, and welcome to this Hangzhou.